Thank you all for having me. I'm going to talk about approach to stroke imaging, focus mostly in the acute stroke setting, but got a little bit of subacute in there as well. I have no disclosures. And the goals and objectives of this, I'm going to review sort of optimal use of some different imaging modalities in the evaluation of patients presenting with stroke-like symptoms. And I'm going to talk a little bit about using cerebral perfusion imaging to triage emergent stroke therapy, certainly endovascular therapy, and review the use of some advanced imaging to help diagnose some rarer causes of stroke. And again, I'm going to start with acute stroke, that being, of course, occlusion of a vessel supplying brain parenchyma, resulting in ischemia or potentially death of that dependent parenchyma. And as you all know, there's a lot of etiologies for stroke. There's, of course, the, acute arterial occlusion or high-grade stenosis, but, veno-occlusive disease, of course, can cause venous infarcts. And then there are these other pathologic entities that cause narrowing of arteries and then resulting in ischemia and stroke, that being, luminal narrowing caused by CNS vasculitis, reversible vasoconstrictive syndrome, also abbreviated as RCVS, vasospasm following aneurysmal subarachnoid hemorrhage, and moya, that idiopathic narrowing of the distal intracranial ICAs and proximal MCAs and ACAs. So you got all these, etiologies for stroke, and as one of my favorite fictional characters is Yoda from Star Wars, and the best tool for everything one must know. And we're going to review some of the imaging tools and some different ways to use them in the stroke setting. This is a case-based session, so I'm going to use some cases from our institution to illustrate some of these points. So the first case is a 48-year-old who presented with 12 hours of worsening headache, no other symptoms, just headache, comes into the emergency department and gets this non-contrast head CT, which of course, as everyone on this session knows, non-contrast head CT is the imaging modality of choice for an acute change in neurologic status. And I read this case, and when you blow it up in a big conference, it looks a little more obvious than when you're scrolling in packs through a study. But you kind of look at it in first glance, you don't see that much. But if you look right here in the anterior occipital lobe on the left here, you see this area of low density with some loss of gray-white differentiation maybe, and some mass effect on the atrium of the lateral ventricle. You can see that in a conference when it's blown up, one picture on one screen, but that can be a hard place and a blind spot for many radiologists and neurologists, this area, because as you're scrolling through, your eye just doesn't pick it up. But fortunately, I do put stroke windows on all of my head CTs without contrast. I'll change the grayscale, obviously, and this really jumps out at you quite a bit more. It becomes a lot more conspicuous, this area of low density, involving gray-white matter, looking like an acute ischemic infarct. And, it's just, I think this is sort of basic, and I think everyone on here knows this, but stroke windows, I think you should always put stroke windows on every non-contrast head CT, no matter what the indication. And it will really help you pick up that subtle loss of gray-white matter differentiation associated with acute ischemia. The typical window levels are level of 32 Hounsfield units and a width of 8 Hounsfield units. And the literature really says that'll increase your sensitivity for detection of acute stroke between 60 and 70%, as opposed to sort of your normal window settings of a level of 20 Hounsfield units and a width of 80. So, again, this is an area, I will tell you, watch this area. If patients will often present with just headache. And so when I see that indication, besides, of course, looking for hemorrhage, mass effect, things like that, I specifically look at this area because patients often don't notice the field cut. They'll just complain of headache. So again, perception errors are radiologist's nemesis, and stroke windows is one of those things that helps us out here. So next case, this was a 63-year-old had known atrial fibrillation, and she was out grocery shopping and developed in the grocery store acute onset of left hemiparesis. So everybody knew she was having a stroke. They were right there. They got her to an outside community hospital within an hour. She got a head CT there that's normal. She was in the window to receive IV TPA in the acute stroke setting, which she received, but she didn't get any better. And typically you'll start to get better, usually within an hour, they'll start to see improvements. And so she was transferred to our hospital to be considered for endovascular mechanical thrombectomy for treatment of stroke. And she got to our hospital at 6 hours and 45 minutes after the onset of her stroke symptoms. So she comes to us. This was her head CT. So her head CT was normal. We had great, everything was fine. We didn't see any hemorrhage. We didn't see any low density edema. In our hospital, in the acute stroke setting, we're, of course, going to get the non-contrast head CT. The next thing we're going to get is CT angiography. And we're going to do this on all of our acute stroke patients to look for that large vessel occlusion, that distal ICA, proximal MCA, ACA, vertebral, basilar artery as the cause of the stroke. And this is that patient's CT angiogram. And you can see the contrast here going out the right MCA. And if you look here where the right M1 segment should be, there is no contrast. So we have an occlusive thrombus here in our right M1 segment. You can see it right here. So on all of our CTAs, we're going to have our technologists send over what I call the 30 millimeter thick MIPS, the maximum intensity projection, where we have the thing densest in the voxel being contrast. And these are really nice. If you can get these sent over with a CTA, it's really helpful to get a good kind of look at the entire vascular tree. And here on the left, you can see we have nice MCA, M1, 2, and 3 segments here. But if you look here on the right, here we've got the loss of opacification of that M1 segment being occlusive or nearly occlusive thrombus. We do have some enhancement of some distal MCA vessels from either collaterals or it's a high-grade stenosis here. So that's the source. And on all of our CTAs, I will say we always do 3D reconstruction of the vasculature. We do this on a thin client. It takes a couple of clicks of the mouse, and we can get a beautiful 3D surface rendering of the vasculature. And here is on this is the right side. I will say that this software flips right and left, so you have to kind of pay attention to that. But you can see here in our patient, here is that MCA, and you just see the MCA cutoff where we have an occluded M1 segment here. Here's the left, looks good, our anterior cerebral arteries. Here's our basilar artery. And I will say that one of the reasons I'm really careful to always put my CTA on a 3D is I don't really need it for this case. We're going to all see an M1 occlusion without any problem. But what can be very tricky are distal M2 occlusions or M3 occlusions. And our endovascular interventionalists, they can go after these kind of distal M2 occlusions. And those are very hard to pick up sometimes on axial imaging because they're out in that Sylvian fissure. So I would be, if you're using CTA, I would say absolutely look at the 3Ds because it can be very helpful to see both proximal M2 as well as M2 and M3 branch occlusions. Also distal A2 and pericallosal or distal PCA segment occlusion. So don't forget to use the 3D reconstructions for that. So we know she's hemiplegic on the left. We have a right M1 occlusion. So the question now is, she's almost 7 hours out from her stroke symptom onset. She has gotten TPA. She did not get better. So the question is, should our endovascular interventionalist take her to the angio suite and do a mechanical thrombectomy? Should they go in and they can deploy a stent into the thrombus and retrieve it? And that's a good thing to do if the brain parenchyma supplied by the MCA is just ischemic but salvageable as opposed to completely infarcted. So we need to figure out for our interventionalists as best we can, do we have a large core infarct, or are we dealing with penumbra or salvageable brain tissue here? And the way we do it here, and I'm going to talk about some different ways, but there are several ways you can figure out penumbra. One of them is just with your non-contrast head CT, okay? And that is using the Alberta Stroke Program Early CT score, or what we call the aspect score. And that is, for those that aren't familiar with it, it actually quantifies the non-contrast head CT changes for early middle cerebral artery stroke. It's really for MCA stroke patients. And the idea is that the more areas of low density, meaning the more areas of edema that you see on the non-contrast head CT, that suggests a poor outcome for a patient that has an MCA occlusion. And it turns out that patients who have aspect scores that are greater than or equal to 8, they actually have a better chance for an independent outcome. So there are a lot of places that will just use, especially in the early time periods, certainly 4 hours and under, they'll just use the aspect score to determine penumbra. And kind of the way this works is you start with a score of 10. And you deduct 1 point for every region of the MCA that's involved, every region that you see low density. And this is kind of the list. And you don't need to look at that. This is a great kind of graphic from Radiopedia that I pulled just because it's a beautiful graphic. But basically, you'll take a point off if you see low density in any of these areas: the caudate, the lentiform nucleus, the internal capsule, the insula, the lower inferior MCA territories, and then the higher MCA territories. And so the way this is a different patient. This is a patient that came in, this is the CTA, and they had a left M1 occlusion. And if you look over on the non-contrast head CT, we see that low density edema in the caudate head here on the left, and in the putamen, the lentiform nucleus. So we're going to take, for the aspect scoring, right, we're going to take a point off for the caudate and a point off for the lentiform nucleus, because those were the two things involved. We're starting at a score of 10. So this person has an aspect score of 8, which actually portends a pretty good prognosis for independent living. But that's one of the things you can use to help you determine if there is penumbra, certainly in the early stroke symptom onset period. So this was our patient, and we rescanned her. She had a normal head CT. She did not have any areas of edema, so she had an aspect score of 10 at this point. Now, I will say aspect score was really developed for the early stroke period, and we're now more than 6 hours out from stroke symptom onset. So when we're in the delayed time period, in that 6 to 24 hour time period, here we are going to use CT perfusion to look for, to evaluate for penumbra. And we're using CT perfusion using the Rapid Artificial Intelligence software. So the way this works, we're going to scan the patient. We're going to give another, after we've already done the head CT without contrast. We've already done the CTA and seen that we've got a proximal MCA occlusion. We're going to give another 40 cc's of contrast. And then we're going to scan for about 70 seconds. And of course, we're going to lower the KV and MA so that we're decreasing the radiation dose. And then we're going to use the rapid AI software to process that perfusion data. And there's a few reasons that we use the rapid software. And I'm going to put it out there. I do not work for Rapid. I don't work for the company. I have nothing to do with it. It's what we use here, but there's some good reasons that we use this and that we've chosen to use this. One of the things is it is quantitative. There are other CT perfusion packages that are really qualitative, but Rapid is quantitative, and I think a lot of us really like that. It's automatic. It sends to PACS in under 2 minutes, so it doesn't require the radiologist to process it, which is really helpful. And then it is the other reason we use it here at Wake is that's the software that was used in the clinical trials, specifically Dawn and Diffuse 3, that were the clinical trials that were performed to aid in that treatment selection in the extended time window for thrombectomy, meaning, those studies showed that patients in the 6 to 24 hour stroke period after last known normal, some of those people would be good thrombectomy candidates if they have a lot of penumbra and not a big core infarct. So these are the reasons that we used rapid AI with RCT perfusion. So how do we use it? And again, some of you may already know all this, but for those that haven't gotten to use the software, this is what it looks like on PACS. This is what the CT perfusion, it'll come up. This will be, one of the windows on PACS for you. And there's the first thing that comes up is the summary slide. And it has two parts. It has this part over here, and this is what we call the Tmax greater than 6 seconds. And what that is, that's going to show you the hypoperfused volume of brain. And this is anything where there is more than a 6-second delay for the peak contrast density in the voxel is going to be green on this. So if there's basically a delay of contrast reaching its peak in a voxel of more than 6 seconds, it is going to be green on this Tmax greater than 6 seconds. And the studies using Rapid basically showed that these green areas are areas that are likely to go on to infarction if reperfusion is not established for those areas. So for our patient with a proximal MCA occlusion, it makes sense that a lot of the MCA territory, there was a delay in the contrast peak because the vessel's occluded. And this says, well, these are areas that are going to go on likely to infarction if you don't reopen the MCA. All right. So that's this part of the summary map. The second part is this side. This is called the cerebral blood flow, or the CBF, less than 30%. And what this is looking for is for areas where the blood flow is reduced to only 30% of normal, meaning it's 70% less cerebral blood flow than a normal area. And if you have blood flow in an area of the brain that's less than 30% of normal, it will be pink over here. And it turns out that pink areas are defined as core infarct. So any areas where the blood flow is diminished to less than 30% of normal, that the studies on Rapid have shown that that is core infarct. So you can open that MCA and you can't, that area of the brain is already infarcted. You're not going to save it by doing a thrombectomy. So for a patient like this, which is not our patient, but this patient came in with a left hemiparesis, CTA showed that they had a proximal MCA occlusion. So if we look at our Rapid summary slide, we've got here, you can see areas of Tmax greater than 6 seconds. These green areas show us that these are areas of hypoperfused brain. If we don't open the MCA, these areas that are green are going to go on to infarct. But if you look over here, we have some areas of pink. These are areas where the cerebral blood flow is down to less than 30% of normal. So it's reduced by 70%. And these pink areas are already infarcted. So if we open up the MCA, these areas we cannot save. However, if you look, there's a mismatch. These rows go together. And you can see there's a mismatch between this and this. While this part cannot be saved, there's pretty large areas of the MCA territory that are not pink, but are green. That's a mismatch. Those are areas of penumbra, and those are salvageable areas if we were to open the MCA. And these areas there's a lot of actually penumbra or salvageable brain here. So this would be a patient you would open the vessel up. So some of you might ask, well, how does this cerebral blood flow less than 30% compare with DWI, or restricted diffusion on MRI? And it turns out when they did the studies on RAPID, a cerebral blood flow reduced to less than 38% actually best predicts areas of restricted diffusion on MRI or stroke on MRI. But they did find that sometimes if they used the cerebral blood flow of less than 30% as if they used that as the threshold, it could overestimate core infarct volume. So instead, they'll use the 30% because they don't want to ever overestimate core infarct, because you don't want to exclude appropriate candidates for thrombectomy. So with that, there's a couple other things. You don't want to stop only at the summary map. I think a lot of the neurologists just stop here and just say that's enough. But my advice is to also RAPID sends over some other perfusion indices that can help you. And those are the hypoperfusion index and the cerebral blood volume index. So you get your summary slide first, and then you will get on PACS, it'll give you this Tmax threshold map. And while I mentioned before, we use the Tmax greater than 6 seconds to define that hypoperfused brain. A threshold map will look at that in more detail, Tmax greater than 4 or even 10 seconds. And what it will do, it will calculate this hypoperfusion index. And the way it does it is by dividing this Tmax greater than 6 by the Tmax greater than 10 seconds. And it'll give you this number. Well, what does that number mean? Well, it turns out the hypoperfusion index, when it's greater than 0.5, that is actually associated with someone that has poor collaterals and more rapid infarct growth and poor outcomes. So these are the patients that we need to probably get to thrombectomy faster if they're a candidate. So the other value that PACS will bring up, this all comes over for you onto PACS, is the cerebral blood volume threshold map. And I don't necessarily look at these color images, but I will look at this calculated cerebral blood volume index, and it automatically calculates that. And it turns out if that number is greater than 0.7, it indicates someone that has better collaterals and slower infarct growth probability. So that's someone, while we want to get everybody to the angio suite for thrombectomy as quickly as we can, we maybe don't have to rush that person. We can make sure that we have things a little more in control. So, again, I think the neurologists don't use this as much as the radiologists do, and we're trying to get our neurologists to use it a little bit more, but use those two indices, the hypoperfusion index and the cerebral blood volume index, to really help you with collateral blood flow estimation. Again, if CBV is less than 0.7 index and hyperperfusion index is less than 0.5, you're going to have good collaterals. If it's the reverse, you're going to have poor collaterals. And these people, we need to move to the angio suite really quickly. And we'll tell our neurologists that. We'll say, this person does not have good collaterals. You need to kind of move along. So back to our patient who was grocery shopping with our MCA occlusion on the right. This was her RAPID summary slide. So we have areas of hypoperfused brain at risk for infarction, but we don't have any pink areas. So we have no core infarct at all here, but we have a lot of MCA territory at risk for infarction if it's not reperfused. So is she a good candidate for thrombectomy? You bet. She's the best candidate for it. She had a large area penumbra, meaning she had a large area that was green, no areas that were pink, no areas of infarction. So these are actually the best candidates for thrombectomy. In fact, she went to the angio suite, had a thrombectomy. Basically by the time we got there, she was, almost at 8 hours, and she made a complete recovery. So how do we look at all this imaging fast? We're in the acute stroke setting and we got to go kind of quickly. This is kind of how I do it. The non-contrast head CT it just remains incredibly important, and it's worth just taking, just take a breath and look at it very carefully. We're of course going to use it for acute hemorrhage. We're going to look for a mass and mass effect. But don't forget to look for those areas of low density with loss of gray-white differentiation, that aspect score. Because if you don't have MRI or you don't have CT perfusion, you can use the non-contrast CT to help you figure out penumbra. If your non-contrast head CT is normal and you've got a proximal MCA occlusion, that's probably someone that does have a lot of penumbra and is probably a good candidate. So you don't have to have CT perfusion to look for penumbra. But if you do, after my non-contrast head CT, I then jump to the perfusion analysis because that's a quick way for me to see, is there likely a large vessel occlusion? And then when I see that, then I go to the CTA and I look and I find that large vessel occlusion indicated by the CT perfusion. Again, do not forget those 3D reformats I showed you of the CTA to look for things like an M2 origin occlusion or a distal M2 occlusion or a distal A2 occlusion. I think we're not as good at seeing those on axial imaging. If CT perfusion says there's not a large vessel occlusion, then I take a breath because the patient's not going to be going to the angio suite. And then I just go through my search pattern. I run each vessel up on the axials from the origin all the way up and then look at the reconstructed images. So next case. This was a 72-year-old female who awoke from sleep with a left hemiplegia. She was last known normal 5 hours prior, so she was not going to be a candidate for IV TPA. And so she comes to our hospital. She got a head CT that was normal, so she had an aspect score of 10, which is great. But this is she gets the CTA, and she's got an MCA occlusion, and this is her CT perfusion analysis. So she's got an M1 occlusion. So the question is, do we take her to the angio suite? She's not a candidate for TPA. So here you can see we've got a large area of green where the Tmax is greater than 6 seconds. This is area, and it's really almost the entire MCA territory. So this is area at risk if not reperfused. But when we look over here at the cerebral blood flow less than 30%, we have large areas of pink. So we have large areas of core infarct. And while there always is a little bit of preserved brain or penumbra, when we look at this infarct is too big. And so the core infarct, nearly the entire MCA territory is infarct. This patient's not going to get a lot of benefit out of thrombectomy, so we did not take her to the angio suite. Not a big enough mismatch between core infarct and hypoperfused brain. So she had a large core infarct with only a small amount of surrounding penumbra. And when we looked at her hyperperfusion index and her CBV index, she had very poor collaterals by the rapid perfusion analysis, which makes sense. So next patient. This was a patient given to me by a friend who works in another hospital. And this was a 60-year-old female, came in with an acute onset right hemiparesis. She has a stroke score of 20, so she was hemiplegic on the right. She had a normal head CT and an aspect score of 10, right, which makes sense. She was in the TPA window, so she was given TPA, but she did not improve. So they wanted to take her to the angio suite for mechanical thrombectomy. Well, my friend's hospital does not have CT perfusion. They don't use CT perfusion. Instead, they use MRI diffusion. So she got a CTA next. So you can see on her CTA, here's her left MCA, and you can see a cutoff. So we have an occluded or high-grade stenosis of her left kind of distal M1 and M2 segments on the left MCA. Here's her carotid in the neck. Her common carotid and internal carotid is normal. So it's just a left distal M1, M2 cutoff. They then took her to MRI, and this is how they assess for penumbra. So we talked about you can assess with non-contrast head CT. You can use CT perfusion, but you can also use MRI diffusion. And when he does this, they don't do the whole MRI scan. They just get the diffusion, ADC, and the flare. And you can see there were some areas of these turned out to be restricted diffusion. They were bright on the diffusion, and they were dark on the ADC. So she has an occluded proximal MCA, and she does have some infarct already. You can see this infarct, but she also's got a large area supplied by the MCA that's not infarcted. So, of course, this is all going to be penumbra. So this is how you do clinical diffusion mismatch using the diffusion-weighted imaging to assess penumbra. So does have core infarct, but has a big penumbra, so they did take her to the angio suite for thrombectomy, and she did very, very well and made, got a lot of function back in time. This was her 24-hour post-CT, and you can see those areas that restricted diffusion are low density now on the CT. So this is the infarcts, but the rest of the brain was fine. You can see that these kind of match up with that pre-procedure MRI. All right, next case. So this was a 73-year-old male who presented with a new left hemiparesis. Head CT was normal, so aspect score of 10. We next did a CTA, and I'm going to show you, this is the aorta, just to orient everybody. And this was the left common carotid artery, and you can see right here we have loss of opacification of the left common carotid artery. So we have an occluded left common carotid or high-grade stenosis here. We did CT perfusion, and you can see we did have areas of Tmax greater than 6 seconds in the MCA and MCA watershed or border zone territory. Of course, here you've got MCA and ACA, and this brain parenchyma right in the middle, of course, as you know, is our border zone or watershed territory. And our cerebral blood flow less than 30%, we have no areas of pink, so we have no core infarct at all. So this looks like a great candidate, right, to open up that common carotid artery, because it looks like this is brain parenchyma that may go on to infarction if not reperfused. This is a case where I would be very careful. So one of the questions our interventionalists will ask us when we have an occluded common or internal carotid artery in the neck is, do we think it is old or new? And one of the things that also comes with the rapid perfusion analysis to PACS, in addition to the summary slide and the threshold maps, are these perfusion color maps. We get the cerebral blood volume map, we're going to get our Tmax map, but we're also going to get the mean transit time map. And these, a lot of people used to think that these two things are the same, but they are not. I mentioned before, Tmax measures the time it takes for you to get the peak density in a voxel, okay? But mean transit time actually measures the time it takes contrast to go across a capillary bed. And as it turns out, if you have a chronic or an acute occlusion of the carotid artery in the neck, the Tmax is going to be elevated. Here's your scale here. It's going to be elevated in both chronic and acute occlusions. But in a chronic occlusion, the mean transit time will only be slightly elevated because those people presumably have good collaterals. And while it might take a while for the contrast to get to the capillary bed, the transit time across the capillary bed is only slightly elevated. And the cerebral blood volume is either going to be preserved or elevated. So with this color maps, this is suggestive of a more chronic occlusion potentially with a patient that had collaterals. And this is important. It'll look like this on PACS as well. And then, so when they ask you if you're using rapid perfusion or any CT perfusion for that matter, is the left carotid occlusion new or old? One of the things you want to look at is if the Tmax is delayed, but the mean transit time, cerebral blood flow, and blood volume are relatively preserved, then you need to consider you may be dealing with a chronic occlusion or stenosis that's well compensated with collaterals. And maybe the patient started having stroke symptoms, so they got a little hypotensive and their collaterals didn't hold up well. And you want to tell the interventionalist this because instead of going in there and just opening up the carotid, they're going to first kind of inject the other arteries, the contralateral carotid, the posterior circulation to see, am I dealing with someone that's got beautiful collateral flows? It also suggests it's a chronic occlusion because in general, you don't want to open that up. So this is where radiology can be really helpful in the stroke setting for trying to help our interventionalists figure out, if an occlusion is maybe old or new. So I've spent a little time on CT perfusion, because there's some pearls and pitfalls with that. One of the things you have to remember is CT perfusion is a snapshot in time. Once you get the patient off the CT scanner table, the perfusion could change, but it will identify at the time of scanning blood flow abnormalities that suggest tissue that's likely to be irreversibly injured. That's what it does. I mentioned be careful that the Tmax maps can overcall penumbra in chronic occlusions, like chronic ICA occlusions. And the other thing I was mentioning, that rapid AI software, it's not supposed to label old strokes or encephalomalacia. That pink overlay is based a little bit on Hounsfield units. If the Hounsfield units get really low, like in old infarcts, it won't show up pink, but occasionally it will, so you do have to be careful to look for that. And the other thing I was going to mention is in hyperacute stroke. Those are the strokes where you have the patient in the hospital who develop stroke symptoms and you get them right on the scanner. So you're scanning them, really within the first 30 minutes to an hour, as opposed to cerebral blood flow less than 30% to call core infarct. We're going to use 20% in the hyperacute phase, that phase like we're in the first hour of imaging, so that we don't, that actually has been shown to more accurately estimate a core infarct. And again, we want to have a stricter threshold so that we basically allow as many patients access to thrombectomy as we can. So as the radiologist, that's important for us to kind of let our neurologists know, hey, in hyperacute stroke, we're going to use a CBF threshold of less than 20%. All right. Moving a little away from CT perfusion. Again, we talked about some ways to assess penumbra using non-contrast CT perfusion, and MRI diffusion. I'm going to move to some other things here. This was a 62-year-old in our hospital, had COVID-19 pneumonia, and developed hypotension with systolic blood pressures down to the 60s for a while. It took them, they put on pressors, but it took them a while to get the blood pressure back up. And after they did, the patient altered mental status, wasn't following commands. So they immediately brought them downstairs to be scanned. They got a head CT that was normal. And so the patient's very confused. So they took them to MRI. And here were our diffusion sequences. This is our ADC map. And you can see here, we have some areas of restricted diffusion, meaning acute ischemia, as you know. And here were some others that were bright on the diffusion, dark on the ADC. These were also dark on the ADC. So we had multiple areas of restricted diffusion consistent with acute infarcts. And of course, they're on both sides of the brain. And you might say, oh, you know, could these be cardioembolic? But if you look at the distribution of the infarcts, they are lining up kind of in a line like this. And this is the ACA territory, as you know. This is the MCA territory. So these are the watershed territory infarcts or border zone infarcts. And when we see those, I think as radiologists, it's really important for us to say that to our neurology colleagues. We've got multiple infarcts in a watershed or border zone territory, because that brings up different etiologies for stroke. Of course, in our case, it was hypotension. Especially if you see watershed infarcts on one side, you're certainly going to want to suggest, say, proximal stenosis, like high-grade stenosis, like a carotid stenosis in the neck. But other things, anything that narrows the lumen of the arteries can cause watershed or border zone infarcts. And one of those things is reversible cerebral vasoconstrictive syndrome, or RCVS, often caused by exogenous toxins like marijuana can do it, SSRIs, some of the antidepressants, vasoactive drugs, amongst other things that can cause RCVS. And the other thing that will narrow vessel lumen, of course, is CNS vasculitis involving the walls of the vessel. So with that, we have this patient that's got watershed territory infarct. So, you know, you're going to think in our case, it was hypotension, but remember these other etiologies as well. So our next case, this was a 40-year-old female who presented with headaches and right leg weakness very suddenly. She comes in and gets a head CT where we've got this acute hemorrhage on the CT in the left frontal lobe, kind of in an ACA distribution. We got a CTA and it was normal. So we've got a parenchymal hemorrhage in the left frontal lobe, a normal CTA in a 40-year-old. We went to MRI next, and you can see on the diffusion in ADC, we have multiple areas of restricted diffusion, the caudate, internal capsule. So we've got multiple acute infarcts. We've got a parenchymal hemorrhage in the left frontal lobe with a normal CTA. And again, this was kind of a MCA, PCA watershed infarct, same person here on the diffusion in ADC. So what are we going to do next? Well, if you have a young patient without a cause for stroke on CTA, you want to definitely take them to the angio suite and do a digitally subtracted angiogram, DSA, catheter-directed angiogram, to get a better look at the vessels, and that's what we did. And here is a lateral view of that catheter-directed angio. And, you know, as you know, blood vessels start out big and they narrow gradually as they become more distal. They don't start out big, get small, get big, get small, meaning the lumen. And if we follow these vessels out, just start following them out. Here's a vessel here. Notice that it gets small, then it dilates, then it narrows, then it dilates. And we're seeing and then it dilates again. And look at any vessel. Here we've got a vessel here that narrows, then dilates, then narrow. So this is highly abnormal. We have multifocal luminal narrowing and dilatation in our vessels. You can follow any vessel out. Here's the other the other side. Here we've got dilated, narrow, dilated, dilated, narrow, dilated. This is highly abnormal. And even in our posterior circulation, we have this luminal irregularity. So when we see that luminal irregularity with areas of narrowing and dilatation on catheter angiography, we call that, often say it has a beaded appearance, like a string of beads, we're going to automatically think, is this RCVS, reversible cerebral vasoconstrictive syndrome, or are we dealing with vasculitis? And of course, our neurologists are going to do a lumbar puncture, and they did a lumbar puncture on this patient. And quite frankly, the lumbar puncture was equivocal. It wasn't helpful. So what's the next thing? Now, we can do a brain biopsy, and sometimes that's what you have to do. But how about non-invasive imaging option? And we've now been using MRI vessel wall imaging for these patients. And this is a great sequence. Well, it's a T1 space volumetric acquisition. We do it fat saturated, pre and post contrast, and it is a black blood sequence. I will say if you're going to do this sequence, it's a pretty long sequence. It's over 5 minutes. So if you have a patient that's kind of confused, you may need to sedate them to get good quality. Ideally, if you have a 3 Tesla scanner, it's better, but you can do it on a 1 Tesla, and you're looking for enhancement of the vessel wall. Is it smooth? Is it none? Is it irregular or nodular? And due to the small size of the intracranial vessels, this is why we like to use the 3T scanner, because it has better spatial resolution, and that improves signal to noise. We do these as a 3D acquisition, a T1 space. And the black blood technique, I don't want to get too into the physics, because I'll be honest with y'all, I'm not the best at the MRI physics. Some of my partners are quite a lot better than I am with it. But the bottom line is, the principle is the fact that the blood signal is kept really low on this sequence, black, to distinguish the vessel wall from the lumen. So by making and it kind of exploits the physics that blood's flowing while the vessel wall remains stationary. And so if you haven't seen one of these before, this is what they look like. So it's a T1 sequence. So, CSF is dark. We're going to fat saturate it. We're going to do pre and post contrast. And these are right here. Here are the anterior cerebral arteries here. And notice the blood is black. It's dark. Here's some MCAs. And this is normal. This is what normal looks like. We don't see any, thick enhancement around the vessel walls. Here's an MCA vessels that are black. This is normal. This was our patient with the caudate strokes and the hemorrhage. And if you look at her vessels, we have this sort of irregular, thick enhancement along the vessel walls. This one has kind of thick, almost circumferential enhancement around multiple vessel walls. And higher up, even posterior, here's the black blood and a posterior saying we got a thick nodular enhancement along the vessel walls. Here's our hemorrhage that I showed you earlier on the head CT portion. And this turns out, because of the vessel wall had thick, irregular wall enhancement, this would be more consistent with CNS vasculitis as opposed to RCVS. And this patient did eventually go on to a targeted biopsy, and it was biopsy-proven vasculitis. But this really was helpful, seeing this thick, irregular vessel wall enhancement, very suggestive of vasculitis. Intravascular lymphoma is a really rare disease. I've only seen it once, but it can also look like this, just so you have that in mind. I'm going to finish with a couple other cases of 21-year-olds who presented with headaches and stroke-like symptoms. They got head CT and MRIs, which showed multiple infarcts on the MRI. CTA was negative, so we took her to angio, and here again, if you look at our catheter angio on a lateral view, here are our vessels. Look at this vessel. We've got dilated, narrow. So we have that beaded appearance of our vessels on our catheter angiogram. Look at this, narrow, dilated. So once again, does this patient have RCVS as the cause of her strokes on MRI? Or does she have vasculitis, and what should we do next? Well, we did vessel wall imaging to see if we could see any enhancement of the vessel wall that might suggest vasculitis versus RCVS. And this is her case. And this is, I'm going to orient you a little bit. Here's her middle cerebral artery on our black blood sequence. And you can see there's no enhancement along this vessel. Here's her anterior cerebral artery vessels. So there was no enhancement of the vessels. I will say, if you look back here, these were the infarcts that we did that we saw on her initial MRI. And the vessel, this study's done at this point about 10 days after her initial stroke presentation, which is why you can see this kind of very gyriform, thick enhancement of those now subacute infarcts. But if you look at the vessel, we don't have vessel wall enhancement. So this turned out to be, this is very suggestive of RCVS, and it turned out to be associated with marijuana use in this patient. So lack of what vessel wall enhancement, or sometimes you can have some minimal smooth enhancement is okay. That's suggestive of RCVS over vasculitis. And this is also kind of a great case of enhancing subacute infarct. And it just is a reminder, when you're dealing with stroke, infarcts do enhance. They follow what we call the rule of threes. And infarcts, acute infarcts, are not going to start enhancing before 3 days. They will maximally enhance at about 3 weeks. You have to be really careful because they can mimic tumors in this time period. And usually the enhancement has completely resolved in an infarct by 3 months. So rule of threes. Which makes me finish with this case. This was a very recent case of ours, a 72-year-old gentleman who had sudden onset of headache 10 days prior to his admission. And he didn't go to the hospital. He's like, just had a really bad headache, just stayed home. And then 10 days later, he had a witness seizure and then was brought in for imaging. He was imaged in an outside hospital and sent to our hospital for biopsy of what they were calling was a left occipital brain tumor. He had a chest and pelvic CT, which was normal. They were looking for metastatic disease. And this, so I was reading this case, and this was actually a case the neurosurgeons did to prepare to biopsy for an occipital tumor. And this is pretty subtle. There was this kind of area of low density in the ventral left occipital lobe. On this planning CT scan, I said, you know, this looks a lot like the very first case I showed in this talk, kind of in that ventral occipital area, kind of involves gray and white matter. I put my stroke windows on. I was like, wow, this kind of looks a lot like an infarct. So I went back to the outside images, had gotten digitized for us in PACS, and this is what their images look like. And you know, this is pretty non-specific, but again, it's that area of low density in that anterior occipital lobe. It did look like it involved gray and white matter. So I started wondering, this looks a lot like an infarct as opposed to a tumor, but it's sometimes hard to tell. This was the outside MRI, and if you look at this T2, where the CSF is bright, we see edema, hyperintensity, but if you look at the gyrus, the cortex of the gyrus, it looks edematous and thick. And on the post-contrast imaging, there was nothing bright pre-contrast. This was all enhancement. The enhancement looked kind of gyriform. As you can see the gyrus here, it looked more like gyriform enhancement as opposed to kind of round enhancement or nodular enhancement. And again, on the sagittal post-contrast, it just had a very gyriform enhancement. So we went to the diffusion on here, and it's not brightly restricting, but it did look like it maybe still had a little bit of brightish signal on the diffusion, dark on the ADC and the cortex. So we started wondering, are we sure this is a tumor? So we called our neurosurgeons and said, you know, we want to widen the differential on this case. It might be a tumor, but we've got subacute enhancing infarct on our differential. The patient wasn't clinically did not look like encephalitis. Between his seizure, he was completely normal. So we were very concerned this was a subacute infarct. And we recommended waiting to biopsy. And sure enough, it did turn out not to be a tumor on follow-up imaging, but a subacute enhancing infarct. So be very careful of those. They can mimic tumor, and they can really enhance pretty avidly at that 2 to 3 week period, like I showed you on our RCVS patient. And so it's never bad to necessarily recommend short-term follow-up imaging to assess for expected evolution of subacute infarcts, and maybe suggest to your surgeons to hold off biopsy, just to make sure you're not dealing with a subacute infarct. So with that, we kind of went over, looking for penumbra, using CT perfusion. Don't forget, non-contrast head CT remains really important in acute infarct. Vessel wall, don't forget about vessel wall imaging that can help you look for RCVS and vasculitis. And again, be careful of the enhancing subacute infarct that can mimic a stroke. And with that, I'll call it. It's kind of a whirlwind through acute stroke.
Okay. Thank you, Dr. Geer.
Yes.
Okay, sure. So we could start for the Q&A, but there's still no questions from the chat box. I think I'm seeing it now. So if it's okay, can I ask you some questions, Dr. Geer?
Oh, sure.
Sure. Okay, so as the participants here is mostly from Asia and possibly Southeast Asia, one of the complex problem is probably the limitation of equipments in here.
Yeah.
So as you probably explained about CTP application, probably in here, most hospital doesn't have the access to do that because of the equipments or probably from the technology side. Although there's also the application in the specific workstation of the equipment. How do you expect if you want to go through with the cold stroke and also thrombolysis or thrombectomy? Should we just do the CT non-contrast? Is it enough? Or we could do also, we must do like a CTA, although even we don't do the thrombectomy for the patient. Thank you.
So in general, if the patient's in the window for IV TPA, and again, everybody's got to operate. I mean, I want to show you kind of what all is out there, but you have to use, of course, what you have. And like one of my, they're friends of mine here in the US don't have CT perfusion either. And, using just the non-contrast head CT, that's actually, that aspect score is really good for showing you areas that are infarcted or not. It's actually pretty good. So, I mean, I spent some time on the non-contrast CT part because, it is good. And if you have the ability to do thrombectomy, and some places do, some places don't, but if you do, it will help your interventionalist to do CTA if you have that ability, if you've got the contrast and you're able to inject. I will say if you can do CTA, you may be able to get the software for CT perfusion in time. I think they're working to get that where people are going to have more access to CT perfusion software if they're able to do CTA. The advantage of CTA is it helps your interventionalist kind of look for that occluded vessel. So CTA is really great for that. But you don't have to have a CTA to give somebody IV TPA in the stroke setting. And the other thing I will say is, let's say the only thing that you can do is non-contrast head CT. Okay, let's say that's what you've got. And that's a lot of places. That's what you got. It's actually what you can do then is you get the non-contrast head CT, right? You look and see, if it looks normal or if there's a hemorrhage and all. Scan them again in 24 to 48 hours, and then you may then be able to see the edema of the infarct, of course. So that's the other thing. Repeat just non-contrast head CT can also be good for that.
Okay, thank you, Dr. Joe. So
Did that answer that?
Yes, that answered it perfectly. Thank you. There's already questions from the participants from Tari here. The question is for CT perfusion, what are the requirements? What softwares? Could you explain possibly briefly about the perfusion CT technique?
Yes. Now there are, yes, Tari, that's a great question. So if you have a CT scanner and you have a scanner that can do CTA, let's say you've got that. There are multiple software packages that can go on these scanners. You don't have to have the fanciest CT scanner to do this. You do have to have someone from the company probably talk you through it and help you with it, but you don't have to have the very fanciest top of the line flash scanner to have it. Some of the software requires it, but we use Rapid here because that's what the studies were done on. But you can there are multiple different companies that have perfusion software, and you can use one of those as well. And again, I think if you CT perfusion is really, if let's say you do not have capability of doing a thrombectomy, let's say you don't have an interventionalist there that can go in and remove an MCA clot, you don't need CT perfusion if you don't have that person there to do that. Because CT perfusion is really there to help triage that treatment. And I kind of wanted this talk just to show kind of all the different things. Where is stroke going futuristically a little bit? Because I think this group, knows how to use head CT really well. But I would say if you do not, CT perfusion is there to triage who is a good candidate for the angio suite. If hospitals that don't have interventionalists in the United States who don't have interventionalists, they don't use CT perfusion. Okay, they don't do it because, one, you've got to be kind of pretty careful about the radiation for that, of course, because you're scanning someone over and over. So you only really want to have CT perfusion if you've got an interventionalist on site. Does that make sense? Am I describing that well?
Okay, I think it's clear enough, Dr. Geer. So if it is not so need to be clarified, just please ask again in the chat box, Dr. Tari. Here's another question that comes directly to me. I'll try to translate it, Dr. Geer. For the case of acute stroke on pediatrics, on children, what are the pitfalls that we need to know, and what need we focus to see on the images?
On children? Yeah, so that's
on
another
pediatric patients.
Yeah, I will say in children, we do not use CT perfusion. And the reason is in general, if it's an older teenager, we might, but in general, we don't because it's a lot of radiation. And so we tend to not use it in children. And again, in children, most of the time they're not having a stroke, right? They've got some other reason for their neurologic deficit. They have encephalitis or they have a tumor or something like that. But in children, we're going to get a head CT. We will preferentially go to MRI with children. We might do CTA, but if you do not have an MRI, then we will stop at the head CT. on children. We will do CTA, but if in general we prefer MR angiography, MRA in children. As opposed to CTA, we're more careful with the radiation. And again, most children that come in with a neurologic deficit aren't having a stroke. You know, they have some other pathology, and so we tend to try to get the children to MRI for that. If you do not have access to MR, I would do CT, and I'd use CT with contrast in children.
Okay, thank you, Dr. Geer. Hope that answers Dr. Yani. And another question also for pediatric patient about vasculitis. Is there any best protocol for approach of vasculitis patients in children? What modality that you expect to use? Thank you.
So for vasculitis in children, that's so we will use we use MRI again for children. For the radiation reasons, also MRA because they don't have atherosclerotic disease, you know, they have beautiful vessels. MRA is really great. We absolutely do vessel wall imaging in them with MRI. And I did see in the chat, can you do vessel wall imaging with 1.5 Tesla? Yes, you can. You can. And it's still going to be pretty good. The tricky thing that we've learned with vessel wall imaging is you do need the patient to be still. So, you know, that's, you may need to sedate them a little bit if they can't be still. But, and then I also saw in the chat, someone asked about recommended time frame following TPA in our practice. They will do a repeat head CT, they'll do it the following day, so at 12 hours.
Okay, hope that answers. There's another question about the case visit sign in the presentation, Dr. Geer. Is that lymphoma?
Yes. Yeah, actually, I didn't want to confuse folks. That was CNS vasculitis. It was not lymphoma. It was true CNS vasculitis, but on vessel wall imaging, intravascular lymphoma can look like CNS vasculitis, but that 40-year-old had vasculitis, not lymphoma.
Okay. I would like to ask another question, Dr. Geer, about the FUWI. As you presented that, you told us about the 3D FUWI, but there's also the use of 2D FUWI. Is there any pro and cons between both of them that you prefer use 3D compared to 3D? Thank you.
You mean for using DWI as opposed to CT perfusion for penumbra? Or
sorry, for the vessel wall imaging for the 3D and 2D.
We do the 3D because I think you could do 2D. The 3D gives us, we can do that volumetric, and it's a little bit shorter. And we've just gotten really, because you're looking at such small vessels that has given us, we've just gotten better imaging quality. We've tried a few different protocols, and there are 2D protocols out there. The 3D one just it's easier to read, to be honest with you. So that's why we use that one.
Okay. Thank you, Dr. Geer, for sharing your experience. Okay, so I think the time's up for the Q&A. Thank you, everyone, for all of your questions, especially Dr. Geer. Thank you for your time to have us with us, sharing your experience, your cases about stroke. And we will meet again, I think, 2 more weeks for the Asia Education Program again. And I'll go back to JP. Thank you all. Thank you, Dr. Geer.
Thank you all for having me. I appreciate it.
Yeah, thanks, Dr. Geer. I mean, greatly appreciate from our program, from Nat, me, moderator, and all our attendees for the wonderful presentation. for taking your time and being at your office till like 10:15 p.m. right here.
Oh, no problem.
And it's on a Saturday, so I greatly appreciate this.
Yeah, thank you all for having me. I enjoyed it.
Okay. Right.
JP, I would like to announce that our next session is going to be a deep neck space imaging and anatomy from Dr. Patana. He's from University of Washington in Seattle for the next Saturday night U.S. Eastern time zone. I hope to see everyone again next session.
Sure. Thank you so much.
Thank you, Dr. Geer.
Yeah, thank you all. Thank you so
Thank
much.
you. Thank you.